Examination of the lower back really starts with the patient walking in, and assessment of the gait to see if there's an antalgic gait or a short leg gait or anything which may be causing pain or abnormalities in walking. A lot depends on the flow rather than a sequence, and what I'm going to show you right now is a sequence that I use. It's certainly not the only sequence or necessarily the best sequence, but it tends to have a bit of flow and we cover most of what we're looking for. I start off with the patient standing. Just having the patient stand, we can assess the posture, and Monique here of course has a perfect posture. If you look at the lower back, you can see that the vertebrae are straight, and rightfully you should see right down. Clearly we have no intention of exposing Monique today. But there's no evidence of scoliosis, and you can follow this all the way up. And if you look at the iliac crests, the ASIS are about at the same level, which suggests that the leg lengths are equal. Turning her to the side now, what we want to do is to check the range of motion. We ask Monique just to bend down and touch her toes. Now, most patients may be like me and can't reach. Monique reaches there perfectly, and you can see that she maintains a straight back, and there's no sort of elevation of one side or the other. So this is a perfect back so far. And as she comes up, what we were assessing there also was stretching of the muscles and seeing if there was any pain in the muscle themselves. In fact, when there is muscle problems, what I like to do is to actually isolate it, say here, and ask them to bend again. And if on bending the pain remains here, then it suggests that the problem is below the muscles. But if the pain has moved up to here, then it suggests that there's an intramuscular problem. Now, a good special test to do for stress fractures and facet joint inflammation is the one-legged hyperextension test. And this is done by putting the back in extension and flexing the hip and then extending the knee. And you're really loading the laminae and the facet joints here. And of course, if there was pain, you'd see the patient wince as well. We now concentrate on lateral flexion, and we're going to ask Monique to flex to the left. Just looking once again at muscle symmetry and range of motion, and to the right. And then to emphasize problems with the facet joint, we can do the quadrant test. So when she goes to the left, we just put some pressure there and see if she has any pain. And likewise on the right side as well. Rotation is then tested by asking Monique just to twist from one side to the other. Now clearly, if there's some pathology like ankylosing spondylitis or anything else, then further tests can be done, but this is a good basic screen for the lower back. I like to then do some neural stretch tests, and the first one is a slump test. So we ask Monique to sit down, just put her hand loosely behind her back, flex the neck, and extend the leg. Now what we're doing here is putting pressure on the leg and the neck, and if she had any nerve compression at the root level, she'd actually have pain coming down the thigh. Of course, you could get that as well with tight hamstrings, and therefore, to see if it's the hamstring or not, we let go the head. By letting go the head, it takes some pressure off of the nerve, and if there's still pain, it suggests that the hamstrings are tight. Continuing the neural stretch test, the next one is the straight leg raising test. Here we passively raise the leg and look for pain on the patient's face. Now, if the person can go beyond 70 degrees, then there's no stretching of the nerve roots. But if, say at 45 or 60 degrees here, the patient exhibits pain, it suggests that there's some tugging on the nerve roots. This is more likely to happen in the lower lumbar L4, L5, S1 region. But if it is positive and the patient's having pain, then we can confirm this with the Lessig test, whereby we reduce the leg right to the point where the pain goes away, and then hyperextend the foot. And by doing this, once again, you're putting some tension on the neural fibers on the sciatic nerve, and that will cause the pain, like in the straight leg raising test, to run from the back all the way down the back of the thigh. Another thing that I like to do at this point is the bowstring test, if it's positive, where we put the leg at 90-90 and then press in the popliteal fossa, and of course by pressing on the neural components, the pain will once again come up the back of the thigh. While I have the leg here, I actually like to test the hamstrings as well. Not necessarily directly a back test, but it can lead to back problems. We do that by having once again a 90-90 position and extending the leg, and we check the theta angle. Now the theta angle here is 0, it is straight up. If she had tight hamstrings, it might have been, say, 15 degrees, that's from here to here, or 45 degrees from here to here. And that means that she has a tight hamstring. And that, of course, could be the cause of her back pain. Just moving along, we look at the fader test, or the Patrick's test. Fader meaning flexion abduction, Faber, flexion, abduction, external rotation. And when we press down, we're actually stretching or stressing the sacroiliac joint on this side. And if she had sacroiliitis or any other problems in that joint, she would have felt pain. I like to do the Fader test as well, which is flexion, internal rotation, and adduction. So Fader, flexion, adduction, internal rotation. And this is not a back test again, it has to do with hip impingement, but still something that you can do in the flow. Having done that, to complete the examination, you have to check muscle weakness or muscle power, sensation, reflexes, but I will not be demonstrating that today as I think everybody is familiar with that. Now before we ask Monique to turn around, we're going to check the leg lengths because clearly this is very important as well. The leg length is checked by squaring the pelvis and making sure the anterior superior iliac spine is parallel or level at the same level. And to do that, one quick way is to ask her just to flex up her knees, lift up her bottom, and lie down again. And this usually squares the pelvis, and as you see here, the ASIS is exactly at right angles to her body. By doing this, we can then look at the medial malleoli, and once they're at the same length, we can assume that she has normal leg lengths or equal leg lengths. If we wanted to measure them, you'd measure from the ASIS down to the medial malleolus. And if you want to check, that is the true leg length. If you want to check the apparent leg length, you can go from the umbilicus to the medial malleolus on both sides. And that, of course, would give you an idea of the apparent leg length, which would be different if there are adductor contractures or any other problems which could tilt the pelvis and lead to pelvic obliquity. So we move on to ask Monique to turn around so that we can actually get to the back. Again, one would expose the patient a bit more, but we can look at the back, making sure that the back is straight. There's no muscle asymmetry here. And then I like to palpate the midline, just to make sure that there's no tenderness in the spinous process or the interspinous ligaments. It's important to distinguish that from paraspinal muscle pain, or even further afield, because muscular pain, of course, may be outside of the back and have nothing to do with the back itself. I actually like to put pressure on L4, L5 because this is the usual place for lower back pain. The reverse straight leg raising test is then done by lifting the leg, and this does two things. It assesses the muscles, especially the flexors of the hip which you're now putting under stretch, and also checks to see if there's any neural problems by stretching the nerves once again. Basically, this gives you a rough idea of how to examine the lower back. Clearly, if anything is positive, you may have to zero in on what's going on there. Thank you.